and get back to the championship form where you were once a professor or a school teacher or a concert pianist or whomever. We've all had a championship form once in our life, and perhaps you may want to get back to that. This is an approach that can help you do that.
Great, thank you. So we're going to begin the Q&A portion of our presentation. And for any audience member that's interested in asking a question, you can go ahead and raise your hand. And we already have a couple people, and we've just put the instructions on how to do so in the chat. So first question. So I want to get clarification. So we were in a panel the other night, and you were in there with Dr. Brian.
Mm-hmm.
And one of the items that came up was cholesterol levels, and obviously that's a huge concern of people. We've been taught that, especially in this community, that the lower the better. There's an idea that below 150 is heart attack proof. I have T. Colin Campbell coming up next, so I'm going to ask him the same thing about cholesterol. And Dr. Brian was saying something that was counter to that narrative, and you seem to agree. So I don't want to put any words in your mouth, but I want to get clarification on that. So Dr. Brian was basically saying that the healthiest people, or the people who had the best health outcomes, and correct me if I'm wrong, were people who had higher cholesterol. And he was saying something around 240 to 260, if I remember correctly. And and then I believe it was you, or it may have been him, that stated that if you are living a healthy lifestyle and your cholesterol was still high, it could be because your body needs to produce more cholesterol. So can you tell us what the ideal range is, and just clarify that, because it's obviously quite I'll say controversial, especially in this community.
Sure. So that's a great question. So let me clarify what I'll do is this. I'll clarify what my understanding of what Dr. Brian said is that he actually quoted an observation in the Framingham study. In my recollection, he said that individuals in the Framingham study who had longer lifespan just happened to have higher cholesterol. And I think that was the understanding I had. There wasn't a cause and effect. He was stating an observation. Now, and of course that raised eyebrows. When you look at cholesterol, in particular LDL cholesterol and total cholesterol, there are studies that show by reducing LDL cholesterol, you see an association with decreased cardiac events. You have to look at, the totality of things. So, for example, if somebody has gangrene on the foot, so you take a group of people with gangrenous left feet, and they get amputation, or maybe just have people with bilateral gangrenous feet, and they get bilateral below the knee amputation. There's a benefit to amputating the legs in those individuals because they have bilateral gangrenous feet. So if the gangrene gets worse, the patient gets sicker, and so in that population, bilateral amputation is better. But then, if you then do a population observation, and you say people who have amputations have a lower lifespan. I'm not saying this is true, but I'm just making it. People have more amputation, have a lower lifespan, because they're less mobile, they're predisposed to DVTs than people who are ambulatory. So you say, okay, well, this therapy of amputation is effective in this disease state, in this setting. But if you look at a total observation, people with bilateral amputations have a problem. And so both can be true, and you have to understand the context in which those things exist. Let me give you another example just to try to drive the message home. People who are diabetics, who are hyperglycemic, because they're hyperglycemic with diabetes, are worse off than someone who's not hyperglycemic with diabetes. Okay, great. So then if we come up with a therapy and we lower the blood sugar, aggressively lower the blood sugar, they should do better with people who are don't have lower blood sugar is aggressively lower. But if you think, well, okay, that should be the case, but no, it's not the case. There's studies showing that aggressive blood sugar control is not as effective, is worse than less aggressive blood sugar control. So it seems to contradict, but it's not really a contradiction because low blood sugar is not a state function. Low cholesterol is not a state function. And what I mean by that, when I say something's a state function, if something's a state function, it doesn't matter how you get there. In the case of medicine, in these biological markers, it does matter how you get there. And so if you see a situation where individuals who have a lower number for a certain reason, it doesn't mean that the fact that that number is lower in and of itself is going to give them a better overall outcome. It depends on how that number is achieved. It depends on the circumstances, et cetera, et cetera. And so that's really the gist of the comment. And you have to think in terms of associations and not necessarily cause and effect in all of these situations.
Thank you. And so things like statins to lower cholesterol, what are your thoughts on that? Are we actually getting to the root problem of heart disease when we take a statin, or are we just masking a benchmark?
I think we're more masking a benchmark than we are getting to the root cause. Now, if somebody's eating cheeseburgers or whatever case and their cholesterol's high, you get a group of people who are doing that, and you give one group a statin and the other group you don't give a statin, you can probably show a benefit. You can probably show some difference. Statins can reduce inflammation, they reduce cholesterol, and you can probably show, and it has been shown, you reduce progression of atherogenic plaque. So I'm not saying it has absolutely no benefit or potential benefit, but if you look at the totality of it, somebody taking a statin for 20 years, for example, there are also adverse effects to taking the medication over a long period of time. You have to look at, when we look at these studies, the statin drugs, they range from about 2 to 6 years, okay, in certain populations. Okay, so what's the benefit of a statin drug if you do it for 15 years? We haven't done that study. And granted, say, oh, well, they're registry data, blah, blah, blah. But no, we haven't done that prospective study looking at statins for 20 years. And would that study be different? That's the other thing. Drug-drug interaction. We did the statin drugs. Did we have GLP-1 agonists on board? There are new drugs and other drugs that are coming out, new indications that are being applied to the same patients. So we don't know what the drug-drug interaction of a statin with some of the newer drugs out on the market, and could that have an effect on their efficacy? And so there are a lot of factors that are not looked at, and by and large can't be looked at in these studies. And so we have to step back and use a certain level of common sense to say, well, one, these pharmacological agents are by nature foreign to the body. Okay. So nobody's that I'm aware of is born with a genetic statin deficiency. So we're not correcting a biological abnormality. We're correcting a biological marker, which is outside of the range of biological norm, but we may be doing that in a certain way that's either beneficial for a certain period of time, but not necessarily beneficial for a long period of time. So that's what I want people to understand. It's not, we say, oh, heart attack proof. Cholesterol less than 150. I've seen people heart attacks with cholesterol less than 150. That's how you get there. And the other thing is that it takes more. I mean, high cholesterol is not the only thing that causes a heart attack. There's a constellation of things that can come together and cause a heart attack.
Yeah, and I think within this community, when people say heart attack proof with cholesterol below 150, they're talking about by lifestyle changes, not through medication.
Understood. But again, you want to be careful even in that context, because you don't want to measure it on one biological marker. When we look at patients, we look at inflammation, we look at lots of things. Sure. And so you can have an acute inflammatory insult with a low cholesterol on a quote unquote plant. The patient I presented was on a what? Lifestyle plant-based diet. And she's had increased inflammation. I don't remember what her cholesterol was. I don't think it was very high. Now, she didn't have a heart attack. She had acute decompensated heart failure. But again, you have to look at these things in a constellation. You know, the human body is so biologically complex. What I want to convey to the audience is that we shouldn't just break it down to one biological marker. Number one, you know, if we take all the biological markers we know about, there's probably less than a fraction of a percentage of all the ones that we need to know about to understand the body fully. And so we can't, I don't want to just sort of jump to that. Yes, having a lower cholesterol with lifestyle is great. We look at that, we encourage that, but we don't make guarantees based on that. And we don't, you know, use that as the only component.
So speaking of biological markers, in your opinion or your experience, what are the essential medical tests that everyone should consider getting either regularly or periodically to ensure optimal health and early detection of potential health issues?
Typically, what we use is the echocardiogram. It gives you the size and function of the heart. We use a stress test. It gives us information in terms of your hemodynamic response to exercise, heart rate, and rhythm. From the standpoint of blood test, of course, a resting EKG. Blood tests we use, of course, we look at lipid panels. We look at inflammatory markers, C-reactive protein, myeloperoxidase. We look at PLA2, which looks at plaque formation inside the coronary arteries. We look at, you know, particle sizes, particularly with look at the small particles, ApoB. We look at, of course, renal function. We look at blood count, make sure the white blood count is not very high. So these are many of the basic things that we look at, both physiologically and biochemically in our patients.
Thank you. And beyond the medical tests, you know, and obviously including those, what information such as diet, you know, what people are taking as far as supplementation and other things would you also consider in your evaluation of someone's health? And what should the general public be looking at for themselves?
So when we look at diet, we sort of back off. We kind of go to foundational things. So our recommendation for our patients is optimal hydration, fresh air, sunshine, of course, proper sleep, and the like. Now, you may say, well, those aren't all dietary things, but it's really how we are nourishing the body. So fresh air, sunshine, hydration. Now, hydration, for example, you know, many people say, okay, I get a plastic bottle of water. I drink about 8 bottles of water a day. I'm hydrated. We like for our patients to, you know, eat their water as much or more than drink their water, meaning that you want to consume hydrating foods, you know, cucumbers or melons or that type of thing. So you want to hydrate through natural plant foods because that's more structured water. It's probably going to be perhaps the healthier form of hydration. And what we found in our clinical observation, we haven't formally studied this, is that patients are better hydrated when they're consuming plant-derived water. Fresh air, sunshine, of course, movement I didn't mention earlier is also very important because, again, vitamin D is important. You can't get it all in a supplement. You need the radiation from the sun. We sometimes recommend UV lamps for individuals who are not able to get out very much on a regular basis. But yeah, so from a nutrition standpoint, fresh air, sunshine, hydration, proper movement, proper sleep, those things are, you know, they support proper nutrition and the like. And of course, you know, filling your mind with proper things as well. Okay, nourishing the mind. You know, what you read, what you look at, what you focus on a daily basis also has an impact on your overall health. So that's the approach we take from a global standpoint with our patients.
So you just mentioned structured water when in the context of eating your water. What do you mean by structured water?
You know, there's some people have done some scientific work and looking at, you know, alkalinized water. Some people have put crystals in water and they've studied how structured water is better than unstructured water. I don't pay much attention to that. What we've done is, and I said this is on a clinical observation, when we've had individuals, for example, I've had individuals who are on dialysis, who are on restricted fluid restriction. And so when they're on the fluid restriction, let's say 900 mLs a day. when they restrict that fluid to inorganic water, so they're drinking it, they're always thirsty. I've taken similar patients and put them on a juice feast where instead of 900 mLs of inorganic water, they're taking 900 mLs of cold pressed juice. In that setting of 900 mLs of cold pressed juice, they're much more hydrated. Their numbers show them to be much more hydrated, and also dry mouth and all those. The sense of thirst is gone. Patients who are not in stage renal failure, we see them get more hydrated in terms of reducing increase in GFR, reducing creatinine, and other parameters showing improved hydration. So anecdotally, we see improved hydration when you consume plant-derived water. Water that comes through a plant, I think, is biochemically different. And it may, what we approximate when we do these things like crystallization of water or alkalinizing water, it probably approximates what you get in plant-derived water, but I don't think it's quite perfect. And along the lines of plant-derived water, I think plant-derived nutrients in general are better. Now, I put an asterisk by that comment largely because, lots of things are done to our food sources. You're spraying things, the soil's less optimal, et cetera, et cetera. So there's that disadvantage. So we have to be more selective in terms of how we procure our food. So this whole aspect of nourishing the body has become more and more complex over time.
Thank you. So, so your center combines medical and wellness care. How does this holistic approach impact patient recovery compared to traditional medical practices alone?
It has a big impact on recovery, largely because in the context of a very sick patient. So in this case series I mentioned, one example I alluded to rather, was an 82-year-old lady who was wheeled in. She had had multiple heart attacks, stents. Her heart was initially at 20%. She was put on milrinone, and the heart ejection fraction went from 20% to 50%. So even though the ejection fraction was better, she couldn't walk a few feet without being short of breath. She was on oxygen. She was just debilitated. And so by putting on the integrative approach, she immediately started getting better. So the recovery we find is faster because you have to think when someone undergoes a traditional medical therapy, there's an insult to the body. Let's say you undergo bypass surgery or a stent or whatever the case is. There's some level of intrusion and insult to the body that you have to recover from. And the weaker the body, the weaker the frame of the patient to start with, the less likely they're able to survive the treatment. That's why people have to get surgical clearance. Surgeons won't operate on the sickest patients, even if it's bypass. I've had patients come in with heart attack, with lots of comorbidities, heart failure. The surgeons won't even do bypass surgery. The patient's too sick for bypass surgery. Many patients who are theoretical candidates for heart transplant. It's supposed to be the most advanced treatment for heart failure. They're too sick for heart transplant because the body can't tolerate it. So these traditional therapies, which are supposed to be very powerful, are also very taxing on the body. What I like about this integrative approach, it immediately starts to heal. Okay, you saw this patient who's, and that's why I like to present this case, and there are others I have like it, who's very sick. Within hours to days, started getting better. And that's the power of the nutritional approach. And then we add these other integrative approaches, which then have a synergistic effect, which can help with long-term benefit. And we've seen great benefit with this approach. So not only is it more effective, it's more effective in sicker patients. These people were too sick for the treatment. So when you think about it this way, you have treatment A, B, C, and D, okay? In theory, treatment A is your lower level treatment, and treatment D is your highest level treatment. So in theory, the highest level treatment should be able to treat the sickest patient, right? But I've shown you how the highest level of treatment in allopathic medicine is either bypass or heart transplant. But patients are too sick for heart transplant. So what do they have to do? They have to go to the next level. What? Integrative. That's the best. And not only integrative is the best for the sickest, Guess what? It can treat patients at level A2. If somebody come with mild heart failure, they can be treated with integrative too. But it's not appropriate to transplant a heart with somebody with mild heart failure, mild heart disease. And guess what? Integrative therapy can be treated for healthy people who just want to have better athletic performance. So with this integrative therapy, you can treat the sickest of the sick and the what? Wellest of the well, and everybody in between.
So it sounds like conventional medicine, or you're saying, and correct me if I'm wrong, that conventional medicine often gets lost in treating benchmarks and it's not really focused on the end results. If that, assume that's correct, what benchmarks do you find conventional medicine gets lost in focusing on treating that benchmark without really being concerned with the overall health and the outcomes of the patient?
There's several. In heart disease, you mentioned cholesterol is one. Somebody's had any cardiovascular disease or at risk. That's the whole idea. Okay, put them on a statin to lower the cholesterol, get as low as possible. Ejection fraction from the standpoint of heart failure patient, get the EF up. If you have ischemia on stress tests, and you get a coronary angiogram, you see a 70% stenosis, you go and fix that lesion. And so it's all about the numbers, getting the cholesterol down, the EF up, and these things. And I'm not saying these things are inherently bad. It's just that we have to always put these things in context. So benchmarks of cholesterol, biomarkers, inflammatory markers, these things are important things to look at. We look at them ourselves, but we have to look at them in the context of how the patient is doing. So that's why I like the natural approach, because what you're doing, you're nourishing the patient, you're letting the body do the work, and the body's going to get the numbers where they're supposed to be. The information may not always go to 0 or less than 1 as fast as I like, because there are other things going on in the body. The cholesterol may not always come down to whatever that ideal number is for various reasons, because there are various things going on in the body. So I have to recognize that, and maybe I'm saying, well, okay, the nutritional intervention is not as optimal. Maybe we'll improve it, or we'll give it time to see if those numbers continue to come down and continue to improve. So we always have to put these things in the context of how the body's healing itself, and not just strictly look at the numbers without regard to other aspects of the human frame.
So it's very popular, to look at genetics and say, oh, everything's genetics. It's a great way of taking the responsibility off of the individual for their own health outcomes. What role do you believe genetics plays in heart disease and health in general? And how can diet and lifestyle modifications alter genetics predispositions?
Yeah, some mornings I'm being too lazy to get up and work out, I say I'm genetically predisposed to lay in the bed. That's a great question. I get it a lot. The way I like to explain is the following. Let's say, for instance, you're an architect and you draft a blueprint for this beautiful home. And you have all the details, the drywall, the plumbing, et cetera, et cetera. And so you have the blueprint drafted, and you have this beautiful design for a home. However, you go to the empty lot where the home is supposed to be built, and there's no home there. Okay, there's no home there because the home hasn't been built. So the blueprint's there, but the home's not there. What does it take? Well, you have to hire a contractor to then look at the blueprint and then build the home. That's called the expression of the blueprint. So the contractor is the source, and the subcontractors, of course, are expressing the blueprint in the formation of a beautiful home. And so once that blueprint is looked at, and then materials are brought in and is expressed, then you have the home. So let's take, for instance, somebody who has a blueprint for diabetes, type 2 diabetes. Again, they have that blueprint, but you can be born with that blueprint. But you have to hire a contractor to express that blueprint for diabetes. So that contractor is a poor lifestyle. That contractor is a poor diet, sedentary lifestyle, excess animal protein, processed foods, etc. And so if you hire that contractor and give that contractor enough time, just like the contractor may need like 18 months to build that house. Maybe your contract for your diabetes needs like, 18 years to build your type 2 diabetes. So you have 18 years, you're hiring that contractor to express your diabetes genes. So after 18 years, you go see a doctor, says, oh, you've got diabetes. Somebody else has a blueprint for congestive heart failure. They contract somebody to build a congestive heart failure home, and lupus, et cetera, et cetera. Maybe you have several blueprints and you have multiple contracts. So I want diabetes, I want heart failure, and I want lupus too. So I want 3 homes. So it's the expression of the genetics that we have to deal with. So what we have to do with lifestyle, we have to go in and fire those contractors. And then we hire a demolition crew to tear down that pre-constructed diabetes, tear down the pre-constructed heart failure, tear down the pre-constructed lupus, et cetera.
So I just have to say, I love all of your analogies, both today and in the panel. So the term epigenetics has become extremely popular. That's what it sounds like you're talking about. Can you give a definition of epigenetics? And if you haven't already answered it, how
I mean, epigenetics, I like to think of the environmental influences. So that's the environmental influences that trigger mRNA activity that brings about the expression of a condition, if you will.
Okay. So now I'll let you answer this if you'd like to or not, because it's a little controversial. You brought up the term mRNA. One, I'd like to, if you can explain what that means, and then also it's being used now as a technology, and I don't know if a medicine or a procedure in general, and it seems becoming, the plan seems to be that it's becoming more widespread and used in many things. What is your thought on that technology for as a therapy? Is that, in your opinion and experience, and based on the research you've seen, the right way to go? And I'll let you answer the question, or we can move on based on.
I don't mind answering the question. I mean, the mRNA basically basically you have as I said, the DNA. You have to copy that DNA, and you have RNA that's used to copy the DNA, and then certain components of RNA, and then proteins are made from the photocopy of the DNA, which is in the form of an RNA, and then proteins are made that way. So that's an oversimplification, obviously, but I just wanted to kind of say you go from DNA to RNA to protein development at the cellular level. So it's where these proteins are put together when you have the expression of, say, an enzyme or some other molecule that have amino acids and cofactors that then carry out some of the function, whether structural or enzymatic in the body. So that's how our body produces things that carry out a function of our body, whether it's hormonal or strictly enzymatic or structural, et cetera, et cetera. Now, in terms of mRNA technology, we're talking about, immunizations and the like. When you get into this situation where we are manipulating the human body, manipulating the immune system, I think it's very dangerous. The body is fearfully and wonderfully made. And our immune system is designed, we have our built-in immunization and vaccine system. It's called the immune system. And when the body is exposed to a foreign agent, it has the ability to immediately respond to it, and then it has the ability to identify what it is and then create a later response to it. The reason that system breaks down is because the same reason the system breaks down with diabetes, heart failure, and arthritis, all these other conditions. We destroy the body. We put the body in immunosenescence, which we suppress the immune system, or sometimes I should say the immune system's in disarray. And so when you're invaded by a bacteria or virus, an immune system that's in disarray is not going to function properly. And so when an immune system functions properly, you contract a bacteria virus, you immediately address it. You have mucus formation, fever, these types of reactions. Because if the response is immediate, in the context of a healthy, alert immune system, these reactions such as fever, inflammation is not overblown. And so what happens is that the body's immune system attacks, kills, suppresses the invading foreign agent, identifies it, gives it to the secondary immune system, which later on can identify it further, and you have immunization. So we're really immune to foreign agents from the start, even without the introduction of a vaccine of any type. It's just in a healthy immune system. The reason we die from these foreign agents, such as viruses and bacteria, and this is a mechanism of death. This is nothing new related to the recent pandemic. The reason we die from these things isn't because we lack the ability to identify them as foreign. We die from because we have an immune system that's in disarray. And the immune system that's in disarray, that's disorderly, is going to attack us. So think of it this way, to use another analogy. So let's say, for example, you're some billionaire and you have a mansion and you have guards, you have security system. And so your security system, you have guards at the gate, guards at the front door, guards on the roof, they have weapons, etc. And so the guards, when they're alert and attentive, when somebody comes up and they don't meet, the criteria, they're not identified properly, the guard's going to immediately stop the person. And if the person tries to get through, they'll arrest them or shoot them and take a picture and say, this person tried to get in. And so we'll be on the lookout. They'll send them to the authorities. That'll be immediate. But let's say your guards, they're not alert. Let's say they've been drinking. They're not sleeping. So they're a little bit inebriated. So they're not quite conscious. So let's say not only one person comes up to the gate and sneaks by, but maybe 2 or 10 people sneak by because the guards are kind of half asleep, half awake, half asleep. So they don't know if someone's coming in. So they get to the front door guards, half asleep. So they get into the house. So the intruders are in the house, not just one at the gate, but 10 in the house, maybe 20. And then they start to make noise. Then all of a sudden the guards are startled. So the guards are startled because the intruders are in the house. They've penetrated more, and then the guards start to overreact. So now they start to go in the house and start to shoot the intruders. Guess what? They start to shoot the people who live in the house. So there's this mass shooting, random. The guard, they don't know who's who. So they're shooting intruders, they're shooting inhabitants. And you have this major overblown reaction by the guards because the guards are impaired. That's what happens with the immune system. When you have an immune system which is impaired, its response to invasion is not immediate. So therefore, you have more bacteria, virus get in. Then its response is delayed and overreactive. And the mechanism by which people die from, the recent pandemic infection or any bacterial infection is due to an overreactive immune system. It's not due to the virus or the bacteria. The virus, bacteria is long dead. But then it's the immune system over. That's why you have to give them steroids and autoimmune treatments over time. That's why you have things like long COVID or strep throat is another example, well-known example of an autoimmune system that's due to immune disarray. So these things have been existing in biological systems for a very long time. We know this is nothing new with this late pandemic. This is basic biology 101, medical school 101, everything else 101.
So for people who have been exposed to the mRNA therapy, is there any way to clear it out once it's been introduced into the body, or is that part of your DNA now?
That's a great question. I don't have an absolute answer to that question because I haven't looked at the literature. What I can share with you is the following. My understanding, first and foremost, of this is that the design of that mRNA therapy is such that you are given the tools to produce the antigen on an ongoing basis. And so the way it's designed to where normally if you get an infection or you get an immunization, you get an immunization where you get a piece of that antigen that's either killed or weakened, etc. your immune system sees it, reacts to it, creates antibodies, and it goes that route. This system is where you're given a piece of the RNA of the antigen itself. So then you're given that in a capsule, and it's designed to where you then can make that antigen inside. So it's not like the injection gives the antigen, the injection gives the RNA, so you can now make the antigen on an ongoing basis. That's one. That antigen that you're making, it's in and of itself has a toxic effect on the body. And so that's where you get a lot of this long-term effects, because there's an ongoing expression of that antigen, and the antigen itself has a toxic effect. And of course, you're trying to make antibodies to it. Now, of course, that antigen is outdated because the stuff that's in the environment has changed. So what you're going to be exposed to is going to be different than the antigen you're making, because that antigen you're making is based on a previous agent who's undergone a nose change, and so the descendants of that original one looks different. So there are multiple problems. One, because your immune capacity is taken up making an outdated antibody, you have less immune capacity to make an updated antibody to the new stuff that you should be making antibodies to. And that's been borne out even in flu vaccines, where individuals who get flu vaccine are predisposed to other viruses because you're making more antigens for flu vaccine, but then you can't make the to RSV. And so you're predisposed to getting RSV infection after giving this immunization. So the immunization, as opposed to letting your body's natural immune system do what it knows to do, you're tricking the immune system. You're forcing it to do something that it really shouldn't do. And we don't understand the immune system well enough to do that.